Hi, everybody. My name is Luis Raez. We are going to talk briefly today about our last Primo meeting in Hawaii, 2024. Primo stands for recommendations in immunotherapy and oncology. This is a meeting that is going for now close to 10 years. And we are very excited to be part of that. I want to do a small summary about our lung cancer session. Our lung cancer session was very good. I know because I'm a lung cancer expert, but because we review very important topics. For example, we had Dr. Paul Bong doing an update about small cell lung cancer. We have Dr. Matthew Gubens. We have Dr. Edgardo Santos. And basically, the four of us were trying to talk about the latest. For example, let's start with immunotherapy. A very hot topic is neoadjuvant immunotherapy. So I did a review of the four trials presented in the last 12 months about perioperative immunotherapy, meaning neoadjuvant plus adjuvant. As you know, we have this trial showing that if we add immunotherapy before and after surgery, now there is an improvement of survival to the point that one of the regimes, Keynote 671, is already FDA approval using pembrolizumab before and after surgery. That's the standard of care. It's approved. It's controversial too because we have a lot of data of neoadjuvant immunotherapy. We have a lot of data of adjuvant immunotherapy. And before we were able to figure it out which one is better, now we have all of these studies of perioperative, both of them together, showing that there is a benefit for the patients. So anyway, it's good to have options for the patients. And during the Primo, a tradition in Primo is to do a 1-hour tumor board after all of these lectures. And we discussed several cases that are very complicated cases because these are the patients that come and we need to put the surgeon, the medical oncologist, and the radiation oncologist to decide what is the best option for the patient, the immunotherapy before surgery, the immunotherapy after surgery, or as we said, now we are giving immunotherapy before and after. Also in small cell, we review, that it's a very frustrating disease for more than 20-something years. We still use that chemo, carboplatinum metoposide, very frustrating. However, we have data with lurbinectedin that was approved, I think the first drug approved for small cell after 20 years. For second line and beyond. And we have a lot of potential markers like SFNL11, DDL3. So the data is promissory in world lung. Recently, there are several studies with markers because finally, hopefully, we have markers for small cell. We don't have any breakout through yet, but at least the fact that we know that there are markers that can be targeted and the fact that we know that not all the small cell lung cancers are the same. As everybody probably knows, there is 4 types of small cell lung cancers now, and now makes sense. They don't behave well. For example, there is only one type of small cell lung cancer, the one that is the immuno, that responds very well to immunotherapy. The other ones no. So now we really have to divide small cell in groups and try to do targeted studies based on each group, either in the type of small cell lung cancer or based on the markers that I mentioned before. Finally, we don't have a lot of time. We want to mention, we review repotrectinib and all the new agents, targeted agents. I think repotrectinib is very exciting because it's a ROS1 inhibitor and it's still in development as an NTRK inhibitor. We don't know if it will be approved or not. But as a ROS1 inhibitor, I had the opportunity to participate in the study with Trident, and it was very exciting for us that even if we treated close to 100 patients only, we were able even to rescue people that failed the standard of care that is entrectinib, the most powerful ROS1 agent. We have people that had the resistant mutation G2032. Despite the fact that they failed entrectinib, they respond to Repo. Also, the duration of the response is 1 more year than entrectinib. So I know this is not randomized phase 3 trial, it's only a phase 1, phase 2, but the evidence is very compelling using this agent as a frontline, as its FDA approval, because can be FDA approved for first or second line. is probably the right thing to do, and the toxicities are the same as entrectinib or standard of care. And I think that's why our patients deserve the best shot. So we had a debate, of course, because the data, as I said, is not randomized. And I don't want to be biased. I'm one investigator. But I think, the history will say that this is the right approach or not. And finally, in World Lung, there were very exciting data for EGFR patients. As you know, since the World Lung, we're doing EGFR plus chemo as a new option now in new patients with EGFR mutations. And it's a debate if you do EGFR alone, if you do EGFR plus chemo. But also in Primo, we had a long discussion that now in World Lung, also in Singapore in September, the data, in ESMO, the data was presented with amivantamab and lazertinib. Lazertinib is another TKI with amivantamab, the bispecific, as a new option for frontline patients, and the study is positive. That's why we are waiting for FDA approval, but that would be a surprise that maybe in the near term, we will have now 3 options for EGFR patients, either osimertinib alone, as we use now, osimertinib plus chemo, as we already showed the data in World Lung, or amivantamab plus lazertinib, as we show in ESMO. Very exciting because a lot of controversies, toxicity. There is still a lot of people that prefer osimertinib alone. They don't believe in FLAURA2, that is adding chemo. But that's what makes exciting for us as a medical oncologist, that our patients have options. And we spend in Primo in the tumor board discussing a couple of cases of EGFR and EGFR resistant. That is probably something that now we're seeing in our daily life. So thank you very much for this interview. It will be a pleasure to go back with you anytime in the future.